Good morning, everyone. Thank you for joining PHCA for today's webinar, PDPM, a live look-in. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. This webinar is not for credit. I'll be sending a link to a quick survey. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using the questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. Today's webinar is being presented by Mike Nicodemus, Resolution Healthcare Management. Reminder that this webinar is not for credit. On October 1st, a new payment model, the patient-driven payment model, went into effect. PHCA wanted to take a live look into how things are going in the first few weeks. Join us as we take a look at what providers are finding as surprises and solutions in PDPM. Mike will discuss challenges and issues that have arisen along with best practices for operational implementation. There will be a time for, as we talked about before, questions at the end of the presentation that will help you moving in the right direction. I'll now turn the webinar over to Mike.
Good morning, everybody. Welcome to a live look-in PDPM. Here we are, T plus 23 days into PDPM, and this is an opportunity for us to take a look at how it's affecting us in reality versus theory, which we've had up to this point. As Wendy introduced me, I'm Mike Nicodemus with Resolution Healthcare Management. This is a new organization I'm very excited to be a part of. Although it's a new organization, it's definitely not a collection of new individuals. I probably know many of you already. We have a great group of people here with Resolution offering a lot of great services from EHR builds to exciting new ISNP plans, personal care, assisted living, billing, and technology services. Whatever you need, Resolution's got you covered. We have a short window today, so straight to business. So what challenges have we had surface so far? One of the first items that we've really noticed is Section GG. Have you been surprised by Section GG? If you've moved to an interdisciplinary team review for accuracy, you probably have been surprised by what you found under Section GG. If you haven't moved to an interdisciplinary team review yet, you probably want to be considering that now. We've learned that therapists' coding of Section GG tends to go more in line with what therapists have been trained to do, which is to try to establish patients' ability versus what they actually do. And as we all know, what our abilities are and what we actually do are usually two different things. So we've seen a lot of reimbursement opportunities in how we've been coding Section GG. And if you're getting your teams together and getting a true picture of accuracy, you're going to do much better in that area. A surprise item we've seen from some facilities is the habit of skipping the ambulation questions of how does the patient walk 50 and 150 feet. Skipping these questions or answering them as not attempted gives you the lowest score possible for these categories and sometimes drops you into lower paying PT and OT groups. Definitely very important to make sure we're monitoring these on all patients that can do this. Certainly there's patients that this is contraindicated for, but in patients who can, we should be attempting this measure. Assessment reference date setting. Have you changed your processes in this regard? For many years, we were very well set on day 8 is our best practice. That's the day to set for your ARD date of your 5-day. Syncs everything up going forward. With all of those changes out the window with PDPM, What is our new best practice? A very common question we get is, what is my best date to set for my ARD date? Unfortunately, there is no single answer under PDPM. Every patient's unique, and there are many variables to consider when setting your assessment reference date for your 5-day. If the patient had IV fluids in the hospital and you want to capture that for the nursing category, very important to note that that's only for the nursing category, not the NPA components, might be a consideration. If you want to capture restorative or respiratory therapies, you'll need to set it at day 6 or day 7 respectively to be able to capture those areas. We often start by setting the ARD date around day 3 or 4 and adjusting from there. Other things can come up along the way where you might want to move it out. If IV medications start by day 8, you're certainly going to want to capture that in most circumstances. Or perhaps you need a little bit more time to clarify some diagnoses with a physician. We don't want to set the date before we get those in place. So a lot of variables to think about when setting your assessment reference date. No one particularly perfect date to go to. Probably the biggest area that we're seeing overall with providers struggling with is the NTA groups. You have 50 different NTA groups. How do you monitor these 22 MDS NTA items? And how do you learn and monitor the other 28 diagnosis groups and 1,800 plus diagnoses codes associated with these? Unfortunately, there's no real easy way to do this. There is no electronic system that's going to monitor a patient's chart and figure out all these things that are in place. They can help you, but they're not always going to read between the lines and look for other codes where we might want to look into for more detail. The first thing providers need is some extensive training in these NTA categories, and this needs to be followed up by lots and lots of practice. With so many of these NTA groups being obscure diagnoses and others being fairly common, a lot of time needs spent in reviewing and digging around through patients' history to verify that we've met all these diagnosis categories and all of the documentation to support them. Next area that we've seen a lot of opportunities missed by providers is the CVA with sequela. In many patients' chart, you might have a history of CVA, history of stroke, TIA, etc. However, that history of doesn't do anything for you. We need to be able to show that there is some ongoing impact to the patient's care in the last 7 days to be able to code that I-4500 MDS item of CVA, stroke, TIA. This is usually accomplished most easily by finding any type of residual effects from that history of stroke and getting a proper diagnosis to show that. I reviewed a chart just the other day where the patient had history of stroke. There was no sequela, no residuals listed, but then I also noted in the nursing notes that the patient has left-sided lower left extremity and upper left extremity swelling. It's pretty likely that those two things are associated with the stroke. So we want to make sure we're tying any types of diagnoses in and getting those things added. Then we can code I-4500 and get that impact for the speech component. Depression. We've talked a lot about depression. CMS has addressed this many times. CMS estimates that 40% of our population should be triggering for depression. This still remains vastly undercoded. Why is this so undercoded? First and foremost, our patients are predisposed to say, I'm fine. Our entire lives, when somebody asks us, how are you? We say, I'm fine. That's their first instinct. Second, our patients are focused on their acute injuries and getting out of the facility. They just want to get better, move on. They're not really worried about any depression symptoms that they have, or maybe even aware that they have them. Also, patients tend to be embarrassed. They don't want to admit to problems. That's how human nature. We don't want to admit that anything's wrong. So first off, patients are predisposed to not tell us what's going on with them. Second, our interviewers. Our interviewers are uncomfortable asking some of these questions. It's very, very easy to accept when a patient says, no, don't have it, I'm fine, no problems. And when we do code that something's wrong, now we've just increased our workload. We have to address it in cause and care plans and additional liability factors. So everybody's incentivized just to ignore these depression symptoms and leave them untreated. But why is it so important that we don't? Why is it the CMS is incentivizing us up to $40 a patient day if we code depression? Well, CMS has identified that patients have a 66% increased chance of rehospitalization with untreated depression. As, of course, we're all worried about our rehospitalization rates, we've found that many times the depression is a driving factor in hospital readmissions. As a case example, a patient that I personally did the interview on for the PHQ-9 mood interview, along the questions, one of the questions is, do you feel that you've left your family down? And this patient looked at me and she looked at her husband and she said, well, I know I let you down, speaking to her family. You call me fat. You said I'm lazy. And everybody got teary-eyed. It was a very uncomfortable situation. We went through the rest of the questions. She ended up with a score of 14. She definitely had some untreated depression. In follow-up in discussion with the husband, he stated, I said those things, but not like that. I said, you need to do your exercises because you're getting worse. I can see you getting worse. You need to eat the diet that the doctor recommended to you. You need to take your medications and do these things. And he said, I could see her getting worse, and I knew she was going to end up in the hospital. So in her specific case, it wasn't just a risk for rehospitalization. It was her primary reason for hospitalization. It's how she ended up here in the first place. And under our old drug-4 system, we would have treated the COPD that she was there for, and we would have got her some therapy, and we would have got her up walking again and sent her back home. But we never really would have addressed the underlying cause of all of this, which was really her depression. So that's why this makes it so important that we treat this. So again, not just that we're coding depression, but we're incentivized now to actually find these things and make people better. That's the reason for the incentive. There's nothing dirty about it. There's nothing wrong with chasing this. We definitely want to make sure that we're looking at this and making patients better. Very important. So next item that we've seen a lot of misses on, a lot of revenue opportunity for facilities, is under respiratory status. First and foremost, COPD or any other chronic lung, and shortness of breath while laying flat. When I'm doing patient reviews, sometimes just looking at their picture alone in their EHR, I can tell, I just look at that patient and I say, I know that I would never be able to lay that patient down flat. They would have trouble breathing. You see sort of documentation that implies that, but we need to make sure that we're stating that the patient, again, we don't have to actually lay them flat and make them struggle for air to document that, but head of bed elevated because patient complaints of shortness of breath while flat is adequate. The secondary under respiratory status that we see a lot of opportunity is any secondary diagnosis for oxygen use. So patients with COPD, for example, don't necessarily need oxygen. That's not an adequate diagnosis for why somebody needs oxygen. Typically, you're looking at a diagnosis of chronic respiratory failure with hypoxia in these residents, or J9611, ICD-10. In these patients, to code chronic respiratory failure, the typical expectation is 16 hours a day or more of supplemental oxygen. Physicians have some clinical variables that they can consider when making that diagnosis. That's a general expectation. So if you have patients who are on steady supplemental oxygen, they really should have a specific diagnosis as to why they need that. Why this is so important is for a COPD patient or any other chronic lung, again, they already have an NTA score of 2 just for that diagnosis. The added respiratory failure diagnosis gains you another point, getting you to the next level in the NTA categories, give you another $90 a day for the first 3 days and $30 thereafter. On a 30-day stay, that's an average of $40 a day just to make sure that we record that diagnosis properly. The next area we see a lot of errors in has been coding in section I versus I-8000. So we might code respiratory failure in I-6300, but not add the ICD-10 diagnosis in I-8000. For the NTA component, we need that diagnosis code in I-8000. I've also seen CVA sequela diagnosis listed very nicely in I-8000, but then not recorded the CVA in I-4500. So some components need the MDS checkbox item, and some of them need the ICD-10 coded in I-8000 specifically. It's very, very important that your clinicians know where these diagnoses need to be recorded and how important it is that they're recorded in the right areas. Some of the less obvious swallowing disorders have been noted to be a very big component of lost revenue for providers. So what are we talking about when I'm saying the less obvious? I see a lot of notes from the admitting nurse and even the dietitians that say kind of blanket, no complaints of chewing or swallowing problems. But then the same patients picked up by speech therapy because they're not clearing adequately or because they are having leakage from the oral cavity. So some of these less obvious swallowing disorders sometimes are getting overlooked by the admitting nurses and definitely need to be addressed as part of that speech therapy payment component. So let's say that we did do a good job, got through it. Are we ready for our triple check? We got some good coding, got a nice fat rate. So we're all feeling pretty good about things at that moment, right? But what happens when we go to support it? Do we have all of the documentation in place that we need to make sure we can support these items that we've coded? So for diagnoses, do you have the physician diagnosis in the last 60 days? Do you have evidence that it's active in the last 7? Some of these things are much easier to show than others. Diabetes, for instance, as an active diagnosis, you have an MAR with insulins provided, very easy to support. How about aphasia? You have some evidence it was active in the last 7 days. How about that CVA with a history? Are we doing anything for this patient that we can demonstrate that it was active in the last 7? Is the physician diagnosis supported? Generally speaking, we kind of accept what the physicians state as that's it, that's the gospel, but the physicians have to be able to support the diagnoses as well. Care plans and active treatment, are they reflective of diagnosis and services provided? So we want to make sure that everything lines up and matches, that there's nothing contradicting documentation in one area that's against what we've documented in other areas. We want to make sure that everything supports the diagnoses and the treatments that we are coding that are impacting our reimbursement. Remember, supporting diagnoses in these treatments, this is the new COT review when it comes to triple check. This is the #1 danger facilities have as far as compliance liability goes. Every one of these is the same as overbilling a therapy drug level in the past. Being paid for services that we did not provide is definitely something we don't want to get involved in. So we got through this pretty quick. We wanted to save time for questions at the end. We're going to move into that portion now.
Great. Thanks, Mike. That was some good information. Can't believe we're already on day 24 here in the month of October. So, everybody, if you have your questions, we'll take questions at this time. Mike will be happy to answer them. So just type them in the questions pane on the right hand of your screen. Everybody's quiet this morning. I don't know if they're quiet or sleepy.
Well, oftentimes we have a little. Go ahead. I'm sorry.
No, go ahead.
So oftentimes we do have a little bit of shyness of asking our questions on the live webinar. If you would like to send us a question directly, you can follow us on the website listed there. There is a portion of the website where you can submit questions and that sort of inquiries to Resolution Healthcare Management. We can take them up that way as well.
Awesome. So let's see. I have some questions here that we've determined to be important, and they might be helpful to others. Who can code diagnoses to be counted for PDPM scoring? Mike, do you want to answer that one for us?
Oh, I'm sorry. I didn't realize I had muted myself. Anybody can answer these. Anybody can code. It's very important, however, that providers have people who understand what the coding really should look like. Anyone trained and knowledgeable in ICD-10 coding can do it. They want to make sure that they that any time there's not specific information from the physician, that they query back to the physician. There are certain coding conventions that they should be aware of and understand when they are doing their coding. But ultimately, anything can be brought back to the physician to make sure that we're clear about what it is that we're trying to specifically document.
Okay, we have a question from one of our webinar attendees. If you have a long-term care resident that goes to the hospital, has a 3-night stay, returns, and is at baseline, is it best to keep them on for 5 days only and then change the LOC/payer?
So, is it best? Well, that's maybe a couple of different ways to answer that question. If they're at baseline and there's no change, then there's really nothing you could treat from a skilled criteria, because any skilled treatment that you're providing should be based on something that arose during that 3-day stay or thereafter. If there is nothing that arose during that stay, then technically there would be nothing to skill following. Now, you could look at skilling that resident for some days to determine if that's in fact true, to verify and to develop a plan of care for that patient. Those would be possibilities and certainly things I would want to look into. But that would really be a very patient-specific example to be able to answer that with any absolute truth.
Okay, thank you. All right, I have another question here. What is the financial impact of restorative under PDPM?
Well, the financial impact under restorative under PDPM is not a lot. Approximately 25 to 30% of your patients, maybe, give or take on your specific population, could possibly be impacted by restorative at all. The remaining patients, the impact is zero. Before those 25 to 30%, the impact is between $4 and $10 a day, depending on the patient's grouping and also your location and your wage index adjustments. However, keeping in mind that restorative can help supplement some of the services at an efficient way for patients. Sometimes it's a better way for patients to make progress. And also, even though it's only $4 to $10 a day, keeping in mind that your actual reimbursement for therapy services provided is really zero. Although there is money built into your rate, there's no additional money for the actual therapy. There is some additional money for the restorative.
All right. Another question. What is the physician required to document about diagnoses in order to count the DX toward PDPM?
So if you want to be able to count physician diagnoses in your diagnosis listing under PDPM, the REI manual specifies some criteria from the physician's point of view The physician has to document within the last 60 days that that diagnosis is still a current diagnosis. That could be through a recap process. There's many different ways that that can occur. They don't have to specifically write it down. There just has to be a doctor's signature to that diagnosis within the last 60. Of course, then we still need some follow-up on our side beyond the physician, just that the diagnosis is still active in the last 7.
Awesome. All right. Another question is, how often does nursing have to document on diagnoses?
So we don't necessarily need a daily note from nursing to show that a diagnosis is active. Just once in the last 7 days is adequate to show that we could code it under PDPM. However, there's another component to that. If that diagnosis is part of what's skilling that patient, so maybe going back to the first question about the patient who's long-term care, if they have a diagnosis that's either been exacerbated during that time or new, we want to make sure that that might be what's skilling the patient. In those cases, we want to show some sort of daily intervention from a skilling criteria that's why that patient's under skilled services. But as far as coding it on the MDS for PDPM payment, just once in the last 7 days. Clinical practice would dictate probably more than that.
Okay. Attendees, again, if you have any questions, please type them in. We have Mike's time here today, or you can reach out to him directly using the information on the screen for questions. I do have one last question here, and then, again, we'll just see if anybody else has questions, and then we can wrap up and give people some more time back in their day. The last question that I have is, are you allowed to have restorative at the same time as therapy?
Wow, there's a question we get pretty regularly. For some reason, it's been a long-held false belief that you cannot have restorative and therapy at the same time. You absolutely can have restorative and therapy provided at the same time. The only real limitation there is that the two things should make clinical sense. There is no specific rule on any of the items that you can't both be doing the ambulation, you can't both be doing this program or that. It just has to make clinical sense. Now, having said that, the worry that gets into people's mind, especially on the therapy side, is if this ambulation program is so technical that it should be being provided by a licensed physical therapist, then how come they can also be being ambulated by a restorative aid? So as long as you can answer that question with good clinical reasoning, no problem. But it just comes down to, does it make clinical sense these two things are happening simultaneously? If it does, there's no problem with that whatsoever.
All right. Thank you, Mike. Again, we'll give it another minute, and if anyone has any questions, please type them in for us. Hard to believe we've been talking about PDPM for so long, and now it is finally here. We kept hearing it's coming, but now it is here and with us.
Well, and all the things that come with that, the managed care companies may be surprising a lot of us with changing to PDPM at the last minute or even after the fact in some cases. I know many providers got letters dated after October 1 stating that they were switching over. EHR platforms and even CMS letting us down a little bit there with their coding right from the start. I know of multiple providers who are still stuck right now, unable to transmit under the changes with PDPM.
All right. Well, I'm not seeing any questions, so I'm just going to wrap up here. I will be sending a survey along with a link to the handout later today. The recording will be made available on the PHCA website later today if you know anyone who can benefit from it. So please take a moment to complete the survey. Thank you again to Mike for presenting on this important topic, and everybody have a great day.
Okay, thank you very much, Wendy. Appreciate it.